and ovarian cancer risks. Tonight we'll be having two speakers, Dr. Erin Hofstadter and Dr. Elena Ratner, who will be sharing a lot of information with us. There will be an opportunity to answer questions at the end of the evening. Please post them in the chat room. I'd now like to take a moment out to introduce Dr. Hofstadter. Dr. Hofstadter is a breast oncologist and associate professor of medicine on the adjunct faculty at Yale, and she helps to run the breast cancer genetics and prevention program. Dr. Hofstadter.
Thank you so much. Now, this is where the technology comes in. Joanna, did you have my slide? Yay! Oh, thank God. This whole Zoom thing, it's been 6 months, but it still takes some getting used to. Can you guys hear me okay? I'll take that as a yes. Okay, well, let me know if the audio has trouble. But thank you so much to everybody who has taken time out from their evening to talk about hereditary breast and ovarian cancer syndrome. This is the second part of a 4-part series, and so I'm honored to be able to give this part of the talk. And I'll be focusing today on breast cancer risk and management options for women at high risk due to a hereditary syndrome or who may be at high risk due to family history. So next slide, please. Perfect. So I think many of you, many people in general, are surprised to find out that most breast cancer is not hereditary. I know that's the topic of this evening. It's obviously an important topic, but even when families have a lot of breast cancer and they think, gosh, this is running in my family, many times we send folks for genetic testing just to find out they test negative. And we sort of are puzzled as to try and figure out why a family may have more breast cancer than average. In fact, 75% of patients who are diagnosed with breast cancer are due to unknown reasons, essentially. It's considered sporadic. Another 15 to 20% of patients may have more, breast cancer that appears to be more common in a given family. Perhaps that's due to shared risk factors such as smoking or alcohol, perhaps obesity. Only about 5 to 10% of all breast cancers are considered to fall into that truly hereditary genetic predisposition. And of that 5 to 10%, about half of that green piece of pie can be attributed to the genetic syndromes we know best, specifically BRCA1 and BRCA2. Now, that doesn't seem like that much, but when you consider that there's over 250,000 diagnoses of breast cancer every single year in the United States, 5% of that number turns out to be anywhere between 12 and 25,000 women per year. So it's a lot of women out there who might benefit from a more enhanced screening, surveillance, or prevention options. Next slide. So obviously BRCA1 and 2 is what I'm going to focus on tonight. Those are the breast cancer genetic syndromes that we know best and arguably are most common, if you will, in terms of guidelines and what we know to do. But BRCA1 and 2 are only 2 of several breast cancer susceptibility genes, only 2 of the genetic syndromes that are out there. On this graph, you can see in the upper left-hand corner BRCA1 and BRCA2. And on this graph, it shows on the y-axis that the risk that these genetic syndromes confer is actually pretty high. If you have one of these gene mutations, your risk of breast cancer can approach anywhere between 50 and 85%, and I'll talk about that in a bit. But if you see on the x-axis, they're pretty rare in the population. That goes to with what we call TP53 or Li-Fraumeni syndrome, P10, CDH1, STK11. These are very, very rare genetic syndromes, but cause a lot of risk. On the other hand, there are common but very low strength gene alleles, if you will. That's in the lower right-hand corner of this graph. These things, like you can see here, FGFR2, 8q, CASP8, they're pretty common in the population, but each one in and of themselves confers only very, very small risk. And there's a lot of research going on right now to figure out how do we put all these common, we call them SNPs, how do we put all these together to explain risk? And then in the middle of the graph, you can see here PALB2, ATM, CHEK2, BRIP1. These are what we call moderate penetrance genes. They're still pretty rare, but a little more common than BRCA1 and 2, and they confer what we call moderate or medium risk. Instead of a 10-fold risk, maybe they confer perhaps a 2 or 3-fold risk over average. So the take-home point here is that there's more to hereditary cancer syndromes than just BRCA1 and 2, and there's a lot more to learn about these other gene mutations. Next slide. So let's focus on BRCA1 and 2. You've seen, for those of you who attended last week, perhaps you recall seeing similar slides talking about risk, but I wanted to go over those risks briefly again for those who may have missed last week. So no woman who has breast tissue has a zero risk of breast cancer. In fact, the average woman walking around in the US has about a 12 to 13% chance during her lifetime to be diagnosed with breast cancer. However, if you carry a BRCA1 mutation or a BRCA2 mutation, those risks increase to anywhere between 50 and upwards of 85%, perhaps a little bit higher with BRCA1 than BRCA2. For second primary breast cancer, what that means is once you've had a breast cancer, what are your odds of developing a whole brand new one later on? And so for the general population, the average person who gets a breast cancer, their risk for a whole nother breast cancer is somewhere on the order of, let's say, 4% up to, say, 11% during their lifetime, whereas those risks are much higher for BRCA1 and BRCA2. And with ovarian cancer that you'll hear more about later with Dr. Ratner, the average person's risk is actually pretty low. It's only about a 1 to 2% chance. But with BRCA1 or 2, those risks can approach 40 to maybe even as high as 60%. Next slide. There's more to hereditary breast and ovarian cancer syndrome than just breast and ovarian cancer. In fact, the more time that goes by, the more we're learning there are other cancer types associated with BRCA1 and 2. Male breast cancer is exceedingly rare. There's only about 2,000 men diagnosed every year with male breast cancer, but those risks appear to be higher if you are a BRCA2 carrier. The risk of prostate cancer we're recognizing is increased, again, upwards of, say, 30 to 40%, perhaps higher, with BRCA1 and 2. And pancreatic cancer as well is increasingly recognized as part of these syndromes, particularly BRCA2. There's some question about whether melanoma is associated, perhaps some other gastrointestinal cancers, but male breast cancer, prostate cancer, and pancreatic cancer are certainly recognized. Next slide. So what do we do about it, right? Once you know your risk, the question is, what do you do day to day? And for those women with a BRCA1 or 2 mutation, with some of these other mutations I've mentioned, such as ATM or CHEK2, PALB2, others, or for those women with a very, very strong family history, you have options. And that's my take-home message. You do have options. One size does not fit all. And some of the things we'll talk about tonight are screening, enhanced screening is an option. Or what can you do to reduce that risk, meaning preventive surgery, taking medications called chemo prevention, or what lifestyle changes can you do every day to help lower your risk? So we'll talk about that tonight. So key points as I go through each of these things. Ultimately, again, there is no one quote right answer. Every patient who I might see in my clinic comes out arguably with a different answer to their questions because every patient is different. Management truly should be tailored to that patient that's sitting in front of me. It does turn on how old is that person. Not to say that we should be ageist or anything, but what's right for somebody who's 25 might be different than what's right for somebody who's 80. You have to consider, what is the short-term risk? What are the long-term risks? What are the other health issues? Are you currently fighting another cancer? Do you have other competing risks that might threaten your health even more than, say, breast cancer risk? It's important to understand, what are the risks and benefits of the options we're talking about. Are we talking about quality of life, or are we talking about quantity of life, or both? And lastly, what are your goals? Because again, what we care about, I'm in my mid-40s, what I cared about when I was 25 is probably a little different now, and will be different again when I'm 60, 70, 80 years old. So again, your goals may change over time. Next slide. Can't believe I told you I'm in my mid-40s, but whatever. And again, key point, lifetime risks do change over time. So I know I just showed you statistics like, okay, BRCA1, you've got a lifetime risk of breast cancer of 85%, but that's not true for your whole life. When you show up as a 30-year-old lady, you have your whole life ahead of you. A 30-year-old woman with a BRCA1 mutation does probably have a 50 to 85% chance of dealing with a breast cancer at some time between age 30 and, say, age 80 or 85. But if you are a woman who've managed to get to, say, age 65, without getting a breast cancer, you've eaten away at a lot of that risk, and your remaining risk of your life is, it's not 85% anymore. It's much lower. And that's what's demonstrated here on this graph. And if you'll play along with me, if you can see in that gray row, the risk of breast cancer for, say, a woman with a BRCA1 mutation who's, say, 60 years old, her lifetime risk between age 60 and 70 is not 85%. In fact, it's 19%. So again, what I mean to say is the more you go through your life and you are healthy without cancer, the more your overall risk goes down. Risk is confusing. We're all in COVID age, so we're hear about risk all the time, but risk evolves over time. So it's important to make sure you understand where you fall on a risk category when you're considering the risk conferred from a mutation. So again, the take-home point is one size does not fit all. Next slide. So what do we do about it? It's fine to assign a number, but how can we be proactive about managing risk? And so first I'll talk about screening. So next slide. So the guidelines that we rely heavily upon are called the NCCN guidelines. It's a National Cancer Consortium Network, and it's basically the thought leaders in the cancer academic community coming together and really putting their heads together to say what is the best way that we can treat and manage these women. So the NCCN recommends for those women with BRCA, and again this extrapolates to those with other mutations or at very, very high risk, doing a once-a-year mammogram and a once-a-year MRI of the breast, alternating every 6 months. So you get a mammogram, 6 months later MRI, 6 months later mammogram, and that continues starting at age 25. We typically start with the MRI. We do that once a year until age 30, and then once age 30 comes around, it's MRI, mammogram, MRI, mammogram. We do that up until a woman's 75, and then once a person's 75, we say, okay, we have the option to let the MRI go. We can continue on with mammograms once a year, because again, the risk has gone down by that point. It's not zero, but it's gone down. So that's a typical screening recommendation. We also recommend breast exams, and so folks with BRCA mutations will often come to see myself, my nurse practitioner, perhaps their gynecologist, for a breast exam every 6 months. And so throughout the year, you're getting breast exams twice a year, you're getting imaging twice a year, so you're getting kind of 4 assessments spread out over the course of the year. And the whole point of this intensive screening, remember, it doesn't prevent breast cancer, but the idea is early detection. And there's been research that shows with this kind of intensive screening, breast cancers can be caught very, very early at a very curable stage, either at stage 0 before they become invasive, or at stage 1 more than 95% of the time. So in a very curable setting. So next slide. And so, again, why MRI? Why not just mammogram? Well, the MRI and mammogram together, again, as I just showed you, detects breast cancer at a very, very early stage and has been shown to be cost effective. And it's more sensitive. The mammogram is basically an X-ray, and what it's looking for are calcifications, which commonly can form in a cancer. MRI instead is looking more at blood flow and are things lighting up in the breast. It's a little more vague, but it is more sensitive. The trade-off is that they see stuff, and then that opens up this whole can of worms, and they see some enhancement, and should we call the person back for a 6-month follow-up, or should we get a biopsy? So it is a can of worms, but if you can put up with that risk of false positives and put up with that risk of me calling you back for a biopsy, I would say the pros outweigh the cons if you're a woman at high risk. But I appreciate MRI. It's not just going for a scan. It is a whole ball of wax. Next slide. So screening does go beyond just breast cancer screening. And it goes beyond women. So remember, men are equally likely to inherit these mutations as women. It just manifests differently because men aren't at quite high of risk as for breast cancer, and obviously aren't going to get ovarian cancer. So sometimes it can hide in men. But if you know that one of your male relatives has a BRCA mutation, they too should learn how to do a breast self-exam starting at around age 35. In fact, I have some men in my clinic who come in once a year for a chest wall exam. Prostate cancer risk starts to weigh in at around age 45 for men, and screening should be discussed, particularly if that gentleman is a BRCA2 carrier. Remember, I mentioned the possible increased risks of pancreatic cancer and melanoma. And again, though the data is not quite as definitive, we will recommend consideration, at least, of a full body exam once a year to look for melanoma, an eye exam every year to look for, dark freckles in the back of the eye to make sure that there's no melanoma freckle in the back of the eye. Pancreatic cancer, for those people who have a family history of pancreatic cancer, you can consider enrolling into a study called the CAPS-5 study that's looking at whether aggressive screening with ultrasound, endoscopic ultrasound, or an eye or the combination can catch something early. It has not been proven yet. It's still a research study, but it's something that you can consider. And of course, there's ovarian cancer screening, but I'll leave the ovarian cancer screening to Dr. Ratner. Next slide. So there are, as I mentioned, other gene mutations aside from just BRCA1 and 2 for hereditary breast cancer risk. And there's many, many of them, but perhaps the ones that perhaps some folks in the audience have heard more about are these moderate penetrance mutations, ATM, CHEK2, PALB2. These are the ones that aren't quite as strong as BRCA1 and 2, but still puts a person at increased risk. And I show you this graph here, just to show that the NCCN, we care about those people too. And you can see here there's specific guidelines about what do we do about breast cancer risk, what do we do about ovarian cancer risk, what do we do about other cancer risks like pancreatic cancer, colon cancer, and the like. So these guidelines are very, very similar to BRCA1 and 2, and I show you this if only to say there are guidelines and people thinking about this, and that these guidelines are subject to change. You'll notice at the top it says 1.2020. This set of guidelines came out in January of this year, and I fully expect they're going to be updated next year. So it's important to keep in touch with your genetic counselor and your providers to know what's the latest and greatest in terms of screening and prevention options. Next slide. So that's screening. So I would argue as a person with a genetic syndrome, screening I would recommend as a bare minimum for what you should do for management. But then you have options for risk reduction. So we'll talk about that next. So next slide. So of course, thinking about breast cancer, the thing that comes to mind immediately is preventive mastectomies or prophylactic removal of the breast to help prevent breast cancer. Now, to be fair, it is the most effective way to reduce the risk. In fact, it reduces the risk by more than 90%. Nothing's 100%. Remember, it's a surgery. There's a small but possible chance of a breast cancer developing in actually the lymph nodes of the armpit, or perhaps way over on the side of where the breast was removed, because the breast tissue does continue up into the armpit. So there's a very small chance that you could get a breast cancer even though you got the preventive surgery. That said, it's still a very, very effective way to go. Another advantage is you don't have to do the mammograms and the screenings anymore. So instead of showing up every 6 months, you don't have to do that anymore. If you choose implant reconstruction, and I'll go into that in a minute, the silicone implants do need to get checked every once in a while, maybe every 2-3 years, either by MRI or ultrasound, not to look for cancer, but just to make sure that the implant is intact, but no more screening. And the other thing to consider with mastectomies is that you don't have to do breast reconstruction. In fact, it makes it a much simpler procedure if you choose not to get reconstruction. But I would argue most women choose to do breast reconstruction. So the major advantage, no screening, very low cancer risk. However, it's not for everybody. It is a big surgery. It's not like getting breast augmentation, like the plastic surgery shows you see on TV. This is surgical removal of the breast, and it is surgical reconstruction of that breast. It's a big surgery. There is recovery time, typically quoted as anywhere between 4 and 6 weeks, where you're at home, you're not working. If you've got little kids, we've got to figure out who's going to carry the baby around and things like that. So it is a big surgery. Cosmetics can be beautiful, but most of the time you can tell a person has had surgery. And it can take a long time to get it perfect. So I usually tell folks to plan on taking 6 to 12 months sort of as a mindset to know that you're going to be kind of tweaking along the way before you're done. So it's a process. From a body image intimacy issue, sometimes women really mourn, if you will, for lack of a better term, the loss of a major part of their body. And you do lose nipple sensation and breast sensation, and that can be difficult for some women. And I think one of the major points is many people say, well, I don't want to die of breast cancer, so I need to get this done, or my doctor told me I have to get this done. But one of the things to realize is, remember, I told you with screening, we catch breast cancer very, very early. Breast cancer treatment stinks, don't get me wrong. I would not wish it upon anybody. But many times we can treat that breast cancer, cure that breast cancer. And if that person's destined to live to age 85, then they will do that with or without a mastectomy. Statistically speaking, mastectomy doesn't make a person live longer. It may make them live better, but it may not make them live longer. So again, that's where you need to understand what you're buying, and what bang for your buck are you getting with such a big procedure. Next slide. So if you choose mastectomies, and you choose reconstruction, you've got two ways, two approaches to reconstruct the breast, either by putting in a silicone or saline implant, or by doing what we call an autologous or flap procedure, where you literally can take belly fat. Sometimes you can take from the thigh or the buttock, but you take belly fat and you literally use that fat to reconstruct the breast mound. The implant procedure typically is done in 2 stages, where the first stage, the breast surgeon removes the breast tissue, and the plastic surgeon puts in what's called an expander, which is an envelope that gets sewn in place and then gets filled week after week after week until you get to the appropriate size. And then you go in for a second stage, and it's exchanged for a silicone or saline implant. The second procedure is much easier than the first. On occasion, I'm learning more and more that some plastic surgeons are able to go straight to implant, but depends a lot on the breast size and other nuances. I'm not a surgeon, so I won't get into that too much. But on occasion, I hear that some people can do immediate reconstruction. Implants don't last forever. Typically, they get exchanged at year 10 or year 15, so eventually they need replacement. Now, with the flap procedure, some people like that procedure because it's not a foreign body going into their body, doesn't need exchange, if you will, but it is a bigger upfront procedure because you're getting surgery up top, and you're basically getting a hip-to-hip incision, almost like a C-section, to get the abdominal fat removed. So you have 2 places to recover from instead of 1. So many people like it, but again, not for everybody. Next slide. So like I said before, there isn't any magical age, so it's not like you can't do it after a certain age. But what I always cringe at is when my patients come and see me and they say, well, gosh, I just found out I have a BRCA mutation, so I have to get my breast removed, and everyone's telling me I have to do it. But you don't have to do it. Or if you choose to do it, doesn't mean you have to do it right away. So for example, it may not be the ideal thing to do for a woman who's 25, because at that point she may want to have kids, she may want to breastfeed. Her year-to-year risk may actually still be quite low at that age. Conversely, if you've made it to age 75 without a breast cancer, maybe you have competing health issues. Maybe that's more aggressive than you need to be, and perhaps aggressive surveillance may be just as reasonable a way to go. So there's no magical age that you can't do it or you should do it. It's a personal issue. And then thinking of surgeries, I don't want to forget, and again, I'll let Elena talk a lot about this, but getting your ovaries removed is recommended as part of care for women with BRCA mutations and other mutations. If you get your ovaries out at a young age, when you're premenopausal, that actually reduces your breast risk by up to half. Even if you go on hormone replacement therapy, and again, I'll refer to Dr. Ratner on this one, we encourage women to go on hormone replacement therapy, and it doesn't undo that risk reduction. So bear in mind, some of the routine care you might get lowers your breast cancer risk as well. Next slide. So that's surgery in a nutshell, and I'm keeping my eye on the time. I've got another 5 minutes or so. Elena, I'll hand over, I promise. Medicine, chemoprevention. Now, I want you to know that there are medications that have been approved for reducing risk of breast cancer, and those medicines are listed here, namely tamoxifen, raloxifene, exemestane, and anastrozole. Now, I use these medications all the time. They are most effective in women whose risk is related to having atypical cells in their breast or DCIS or something like that. They probably work in BRCA carriers. It's just the data is so limited, it's difficult for me to sit here and say they definitely work. It's certainly worth considering if you're a woman who's choosing to keep your breast tissue. The data that we can get suggests that there is that tamoxifen, of any of these, tamoxifen is the one with the most data. So again, I will offer this to my patients, likely to be more effective in those women with BRCA2 than BRCA1. So I want you to know it's an option, but it, again, may not be for everyone. Next slide. And the reason it may not be for everyone is because there's no such thing as free lunch. Now, while it might lower breast cancer risk, and it can be, some of these medications can be helpful for your bone health, most have side effects, including hot flashes, leg cramps, night sweats, vaginal dryness, weight gain. Rarely, tamoxifen can cause uterine cancer and blood clots. The aromatase inhibitors like exemestane can cause bone thinning. So again, on balance, it's not a free lunch. They've not been proven to make people live longer. You can't use them at the same time as birth control pills or hormone replacement therapy. And remember, I just told you I'm actually recommending that in a lot of my patients. And remember, you get a significant reduction in breast cancer risk by having your ovaries removed. That's what BSO means, bilateral salpingo oophorectomy. So there's some debate in the community right now is how much does it actually help you beyond what we're doing already? So again, worth a discussion, don't get me wrong, but it's not like I'm handing this stuff out to every single patient. Next slide. And then lastly, remember, yes, of course, if somebody inherits a BRCA mutation, that puts you at increased risk for cancer. But remember that very first slide I showed you, most people who get cancer don't have a BRCA1 or 2 mutation. In fact, there's a lot of things that go into risk of developing a cancer. So of course, it's whatever genes you inherit, but it's what we call modifier genes. How are all your different genes interacting? What carcinogens have you been exposed to over your lifetime, such as smoking, alcohol, obesity? What are some hormonal or reproductive factors, even things you can't control in terms of how old you were when you had your periods, how late was your menopause, how many kids did you have, how old were you when you had your kids? A lot of these things you can't control, but everything adds up to sort of, you know, get a person to the brink of developing a cancer. Next slide. So what can you do about it? What factors can you control? So specifically within the BRCA positive and other specifically hereditary cancer syndromes, it's difficult to tease out how much lifestyle change can affect risk. At the same time, we know on a population level it can matter and it can add up. So in general, we recommend these lifestyle changes for everyone from the American Cancer Society. So if you go to I think one of my last slides here, you know, I outline here, this really applies to all of us, especially during COVID as we're all like sitting at our computers all day. But in general, we recommend obviously avoiding tobacco, limiting alcohol to 1 serving a day or less for women, 2 servings a day or less for men. Dietary changes, getting plenty of fruits and vegetables. We're talking like 5 servings a day. Weighing towards whole grains like brown rice instead of white rice. You know, wheat bread instead of refined. And limiting red and processed meats. Be careful of portions. Again, this is what we all know, but I'm just trying to reinforce it. And aim for lots of just a plant-based diet. Now, exercise. Move, right? And especially now during COVID. But what we're looking for is about 150 minutes a week of moderate activity or 75 minutes a week of vigorous activity like jogging or like really, really getting sweaty. So that translates to about 30 minutes a day of walking, of brisk walking. And it doesn't have to be consecutive, even 15 minutes in the morning and 15 minutes at night, just trying to accumulate and moving as much as possible. Another way I kind of think about it is shooting for about 7,000 or 8,000 steps a day. And then lastly, and perhaps most importantly, is really to do all of these things with a goal of achieving a healthy weight. We do know that obesity does increase the risk of cancer, many types of cancer, including breast cancer, uterine cancer, colon cancer in the US population. So that does matter. Next slide. So in summary, right at 7:30, I want you to come away from this talk knowing that you have options. It is not one size fits all. You know, it is a mix and blend of screening, lifestyle modifications, medications, surgeries, and it may vary over the course of your life. So you do have options. Whatever approach is right for you can be tailored to you, and what's right for you may not be right for another person. So don't let anyone else tell you otherwise. And I think that's it. I think, yeah, that's it. So thank you so much for the opportunity. Here is where I hand it off to Dr. Ratner.
Thank you, Dr. Hofstadter. I'd like to now introduce Dr. Ratner. Dr. Ratner is an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences, co-chief section of Gynecologic Oncology, and the director of Discover to Cure. Thank you, Dr. Ratner.
Thank you so much, Ruthann. So Joanna, would you like to, whoever has the control of the screen, can you share the screen and then I'll take it over? Or you can do the slides. Or why don't you just go ahead and then just do this. So, to be here with you. Thank you, Ruthann and Joanna, for doing all this work and getting all of us together here tonight. And Dr. Hofstadter, what a pleasure it is to do these talks with you, and how amazing you are and how much I miss you. And it's just amazing that we're back together doing this, even though it's virtual, but it feels the same. It feels like we're all together. Dr. Hofstadter did an amazing job discussing hereditary breast cancer, prevention, screening, who is at risk, and what can be done. And now I will do similarly for ovarian cancer. As you guys already heard, there's of course a lot of interaction between ovarian cancer and breast cancer, and this is why these talks so frequently discuss both of these sites. It is very important to understand what your family history is. It is so important to understand what you're at risk for, because once you understand and once you know, then you take life into your hands and you do prevention and you do screening and you don't allow things to happen. This is one of the examples of somebody who had a lot of family history and unfortunately did not appreciate it. And then once that family history was really understood, we appreciated how that they were at risk and that a lot of prevention could be done. All right, so the driving hypothesis, which is what Dr. Hofstadter began talking about, is that many patients may be at risk for cancers depending on many different factors: family history, genetic status, personal history. And it is very, very important to know because different women with different risk factors, and that's all part of this individualized care or personalized care that we so argue for, have to be monitored differently depending on what their specific risk is. Of course, our theory is that these women should be cared not by piecemeal by different providers, but by somebody who truly understands what kind of risks they have and is able to do monitoring and screening. Erin talked about different cancers where we believe the genetics are a factor, and there's multiple different things such as early age of onset, multiple affected family members, related cancers. And again, like Erin talked about, it's not just ovarian and breast cancer. It's also very important to remember that there's many other cancers that fit into that family. It is melanomas, like Erin said. It is prostate cancer in males. It is pancreatic cancer. So it is very important to remember that these cancer clusters do not just affect women, they also affect men. And that this is something that really can resonate within families and go from generation to generation. As Dr. Hofstadter said, male breast cancer plays a huge role. You know, in the older days, we used to think that Ashkenazi Jewish ancestry was so important that it explained genetic mutations in most populations, but now we know that's not the case, that there's a lot of other populations that are similarly at risk for genetic mutations, but of course we continue to believe that Ashkenazi Jewish women have a higher risk. Erin already discussed these. There's multiple different genetic mutations and there's many different ones that we see, but BRCA1 and BRCA2 are the ones that we're most concerned about. And in particular for the ovarian cancer, they carry as high as 40 to 60% risk of developing ovarian cancer. In the general population, the risk of ovarian cancer is 1.4%. So these risks for women with BRCA1 and BRCA2 are certainly significantly increased. And again, that is why it's so important to know your family history, so that testing can be done, that if you do carry one of these mutations, they are diagnosed properly, so then decisions can be made accordingly. And that brings us now to the important issues of ovarian cancer. So the trouble with ovarian cancer remains that it continues to be very deadly, and it's for a few reasons. One is that these cancers learn how to mutate, and they learn how to resist the treatment, the chemotherapy treatment that we give, that we're treated with. And because of that, so many of them return later in life and become more and more difficult to treat. And that is why everything that we do right now, it's so important, where we do personalized care, individual care, where we study the tumors, where we treat women very differently, depending on what kind of mutations they have in their tumor. You know, nowadays we do not treat two women the same just because they have the same kind of cancer. We are much better now, much smarter. We know how to understand what drives the cancer, and we know now how to target it better. That is true meaning of this personalized, individualized care that I was discussing before. But the second trouble with ovarian cancer is that, unfortunately, it continues to be diagnosed quite late. Great majority, 85% of these cancers are still diagnosed in stage 3 and stage 4, which makes it a little bit more challenging, or significantly more challenging, to treat. Women with stage 1 and 2 cancers do really well and are cured. That is why it is so important to find these cancers early, at earliest stage. In the older days, a few years back, we used to say, you know, there's just nothing you can do. Ovarian cancer is the cancer that whispers. There's no symptoms. There's just no way to find it early. But we now know that that is not the case. Ovarian cancer is not the cancer that whispers. Ovarian cancer is just the cancer that nobody's listening to. There's been multiple studies that showed, even though great majority of women with stage 3 and 4 cancer have symptoms that are described here, but we now know that as high as 89% of women with stage 1 and 2 cancer similarly had these symptoms. And the symptoms are abdominal distension, abdominal discomfort, some GI symptoms, some vague pain, constitutional symptoms, urinary symptoms, and pelvic pressure. And of course, listening to these symptoms, we all have these symptoms, and most common cause of these symptoms are really just normal hormonal symptoms that all of us women experience. But what separates the normal symptoms from those that actually were precursors or signs of early cancer was that women had more than one, and they had it every single day for 2 weeks. And that is how it's distinguished between the normal hormonal symptoms that is very, very normal for all of us to expect, and the ones that actually were pathologic symptoms. The other trouble with ovarian cancer is not only that it is very difficult for women to diagnose these symptoms, or to really feel that their body is going through something and that is not part of the normal, especially when these symptoms happen during time of menopause or some other hormonal fluctuations. It is also that providers are not good in diagnosing ovarian cancer. Many women who are diagnosed with ovarian cancer see a great number of providers prior to actually finally being appropriately diagnosed. There's a study that was done relatively recently that showed that when the woman finally is treated for ovarian cancer, she likely has had this cancer for 24 months, and she likely has seen at least 6 other providers prior to getting to the right one. And that's because, as you see, the symptoms are so vague, and women are seen by gastroenterologists and by urologists and by chiropractors, and those specialists all are very good at what they do, and they rule out their parts of the disease that it could be, but nobody pieces together that these vague symptoms could mean some sort of a pathology in the ovaries. And that is why so much research is being done and so much work is being done to educate providers, not just educate women, and not just to increase awareness about listening to your bodies and knowing when something doesn't feel right, but also educating providers about signs and symptoms, and not just ruling out what it is that's your field, but also understanding that there could be some sort of a correlation between the gynecological organs. And the biggest lesson of the biggest advice, of course, that I give to women during these talks is to demand the care that you deserve. So many of my patients that come to me say, you know, I went from one to another and everybody was saying that everything was normal and I was just going through menopause, but I knew that something was wrong. And when I do multiple lectures for providers, I always say, listen to the women, listen to the patient. If they tell you that they know that something's wrong and their bodies do not feel right, then you need to listen and you need to do whatever it takes to diagnose it. So the biggest thing prior to a few years back used to be that we used to say there's just nothing you can do. Ovarian cancer is just get diagnosed late and that's just what it is. But we now know that that's not the case. And that is why it's so important that we do so much, again, patient education or women awareness and then provider education for the symptoms. And we know that when women actually present with symptoms of ovarian cancer, the most common physicians or providers that see them are gastroenterologists, urologists, chiropractors, and psychologists. And these are really the groups that we're doing so much education with because of this. So, as I mentioned previously, 21,000 cases in 2020 in the United States, but unfortunately, a lot of deaths. It's the most common cause of cancer death in women with gynecologic cancers and the 5th leading cause of cancer death in women in the US. As Erin already mentioned, you know, this is still what we believe, even though we know this is not to be the case. You know, we used to say that 10% of ovarian cancers are hereditary. We now think it's significantly higher than that. We think it's probably 20%. And I think as the time goes and as we meet again and have these talks over years, I will be able to demonstrate to you that this number is going to be higher and higher as we're learning more and more about genetics and predispositions of ovarian cancer. But as Dr. Hofstadter said, yes, great majority continue at this point to be something called spontaneous, where we do not know a genetic mutation that is associated. But again, similarly, just because we don't know it doesn't mean it doesn't exist. There's unquestionably families that have a lot of cancer that runs through them, that even though we cannot diagnose a mutation, we know some mutation exists, and that's what predisposes them to increased risk of cancer. So let's again briefly talk about, we are talking about risks. So it is very important to understand who is at risk, because for women who are at risk, the methods of screening and prevention and things that we can do are very different. So I already talked about the biggest risk. The biggest risk is genetics. But what other risks are there besides cancers that run in your family or known genetic mutations that run in the family? So early age of first menstrual period, late age of menopause, women who have never had pregnancies, women who didn't breastfeed, women who had infertility are all at higher risk. And the reason for this is twofold. That brings me to the discussion of how do ovarian cancers happen and where do they come from. And there's two different theories. There's the older traditional theory and a little bit of a newer theory that I will discuss. So the traditional theory is that the more times that the woman ovulates, the more is the risk of this carcinogenesis in the ovary. So every time she ovulates, there's increased risk of this carcinogenesis. And the less time she ovulates, so somebody who has not had, who started their periods late, who had their menopause early, who had a lot of children, who breastfed older children, who use birth control pills. And we'll talk about that shortly as one of the things that we can do for risk reduction, that these women have an increased risk if they were ovulating a lot. The second theory of ovarian cancer, the more recent one, is that ovarian cancers are actually not ovarian cancers at all. That ovarian cancers are actually fallopian tube cancers. And that's where these cancers and the rest of the ovaries where they're caught. And we definitely think that this kind of theory of fallopian tube cancers is a little bit more associated with genetic mutations such as BRCA mutations. Infertility is a risk factor with twofold reasons. Infertility is a risk factor, one, because women continues to ovulate and doesn't have that period of time where the ovaries are resting, but also because endometriosis, which is a very common cause, common disease in women, in itself predisposes you to certain kinds of ovarian cancers, such as clear cell cancer and endometrioid cancer. So that is the reason for for infertility to be a significant risk factor. So now that we know who is at risk, then what can be done? And this is very similar to what Dr. Hofstadter talked about previously. There's any cancer that you have, there's always three risk management options. So surveillance, chemoprevention, and then surgery. And of course, you can see that they're going from the least aggressive to the most aggressive. So let's start with surveillance. Actually, you know what, before we talk about surveillance, let me talk a little bit about prevention. So there are things that one can do to decrease their risks of ovarian cancer. We certainly cannot prevent it entirely, but we can certainly risk reduce. So somebody who has had 5 children and breastfed each of those children for 1 year each, that was the plan that I was working on, decreases their risk by 50%. So if somebody's risk is 1.4%, then their risk becomes 0.7%. But more importantly, for somebody who has BRCA mutation, and let's say their risk was 20% or 40%, they can decrease that risk to half. So somebody who had a 40% risk can now have a 20% risk. Similar kind of reduction can be done also by birth control pills. So for any woman who takes birth control pills for 5 years during their lifetime, they decrease their risk by 5 years. Anybody who takes birth control pills for 10 years decreases it by as high as 80%, 15 years as high as 90%. So if you hear anything today out of my talk that you are going to remember, it's this. And this is a point that I make no matter where I am, where I'm being interviewed for something completely different and completely separate from this. I always make this point because this really can save lives. The women who can take birth control pills for at least 5 years during their lifetime, it doesn't have to be consecutive. It could be at any point of their lives, significantly decrease their risks. It has to be birth control pills, or it can be NuvaRing. It cannot be Mirena, or it cannot be an IUD, because it has to be something that stops your ovulation. And then the third thing that can be done to significantly decrease your risk is removing your fallopian tubes. And there's currently studies that are going on for women who are at significant risk, like women with BRCA mutations, whether we can preventatively remove their fallopian tubes once they're done with trying to conceive as a risk reduction. And in those cases, able to leave their ovaries in place for longer so they benefit from the hormones released by the ovary. But fallopian tubes by themselves do not really have a purpose. The only purpose of fallopian tubes is for pregnancy, is for the egg from the ovary to get into the uterus for the implantation. So once childbearing is complete, or if a patient decides she's going to do IVF no matter what, then what we would do is we would remove the fallopian tubes, and that significantly decreases risk of ovarian cancer, likely secondary to the second causality of ovarian cancer that I discussed, that these cancers happen in the fallopian tubes first. So that now brings us to surveillance. Unfortunately, this is different from what Dr. Hofstadter was discussing in her breast cancer surveillance talk. As mammograms and breast MRIs are very effective in diagnosing ovarian cancers, we unfortunately do not have an effective screening method. What is done now is that we do ultrasounds for ovarian cancer risks, combined with the tumor markers such as C125. Unfortunately, these tests are not as good as they are in breast cancer. And unfortunately, even if we do these tests very frequently, we still can unfortunately miss ovarian cancer. But it is better than nothing, and a lot of literature has been done that the best way of doing this kind of screening is the combination of the ultrasound and the CA125 tumor marker, or some newer markers that are now on the market, such as OVA1, once a year. It is important to note that this is not for everybody. This is not for low-risk women, because the risk of finding something abnormal in the ovaries and needing surgery is unfortunately somewhat high. So this kind of a method of attempted screening is truly for women with high risk, who are at higher risk for ovarian cancer. And for those women, we recommend this kind of screening. And now that brings us to the most aggressive kind of risk reduction, which is surgery. So surgery can be twofold, as I started discussing previously. Nowadays, again, a lot of studies are being done about benefits of removing just your fallopian tubes once childbearing is completed, as a method of risk reduction. However, because unfortunately we do not have a great screening method, the current guidelines are such that we recommend that ovaries and fallopian tubes are removed at a certain age for women at significant risk. And at this point, this significant risk really just means genetic mutations such as BRCA1, BRCA2, and Lynch syndrome, for example. And the age at which the surgery is recommended depends on what kind of mutation the woman has, what is her risk, what kind of family history does she have, what age was her family members diagnosed if they had ovarian cancer, and also, of course, so importantly, on whether they have completed childbearing or not. That being said, I have a number of women for whom we removed their ovaries and fallopian tubes in their early 40s, and then they still were able to get pregnant with their eggs and embryos that they were able to save and freeze previously. So I think that's a very important point, and I believe you guys actually have a whole session where you're discussing the importance of fertility-sparing treatments and fertility modalities that are now available to the women to be able to both reduce their risk of cancer, but at the same time be able to have the families that they want. For women who do not have genetic mutation, there's a lot of debate on whether ovaries should be removed prophylactically or not, and at what age. In the older days, 5 years back, 10 years back, we used to always remove ovaries at approximately age 50, 52, if the woman was having some sort of a surgery for, let's say, fibroids or pelvic pain. And this is one of the studies that showed from Dr. Schwartz from Yale that showed that approximately 12% of women might avoid developing ovarian cancer if this kind of prophylactic removal of ovaries was done routinely at the time of hysterectomy for women in their 50s. Subsequently, there's been some studies that showed that there is likely some benefit to the ovaries up to age 65. So we're now much more careful with these decisions, and we truly, again, same as I started before, talk to the women and truly provide personalized, individualized care depending on what their risk factors are. Do they have a risk factor of ovarian cancer or breast cancer, in which case, of course, removing ovaries makes a lot of sense. Or do they have none of those cancers or no cancers at all in the family, but they do have cardiac risk, which is greatly protect against, even again until age 65 or so. And then those women, the benefits of keeping ovaries in place outweigh the risks of that. So again, truly personalized treatment from that perspective as well. Removing ovaries and fallopian tubes in women is very, very effective. So this is one of the studies in BRCA previvors where women underwent this risk-reducing removal of ovaries and tubes versus control. And we can see the women who were controls and had their ovaries still in place had almost a 6% chance of ovarian cancer over this follow-up of 6 years versus only 1% of something called primary peritoneal cancer. What is very, very important to talk about, and I still have 2 minutes, and this is what I want to talk about because it is so, so important. There's a lot of misconception in the community about hormones in women who are at higher risk for ovarian cancer or at high risk of ovarian cancer. And Joanna and I see numerous patients, and it really breaks our heart, who are in their 30s or their 40s and they're super young, and their ovaries and fallopian tubes are removed for this risk reduction. And because there's this misconception of hormones causing increased risk of cancers, these women after that, at that very young age, are not placed on hormones. And there's been a great number of studies and a lot of literature that exists that not only is it safe for the women to be placed on supplemental hormones after their risk reduction and the removal of the ovaries, but it's actually detrimental for them not to be on hormones. And as Dr. Hofstadter noted, when the ovaries are removed prior to menopause and women are placed on hormones, they have a risk reduction of breast cancer that is 50%, so incredible risk reduction in breast cancer, not increased with the hormones. And hormones are so important for the heart and the bones and the mind and how the woman feels that right now the standard absolutely is to place women on hormonal therapy after their ovaries and fallopian tubes are removed. My patients get a patch before they even would leave the hospital. We don't have too much time, unfortunately, at this juncture to discuss progesterone versus estrogen. Besides that, I would just say that if there's one hormone that we sometimes try to avoid is progesterone, and that's why a lot of stuff that happens is whether we put a Mirena in at the time of surgery or we do some other things, is for the fact that we really want women to be on estrogen, and try to avoid progesterone is possible. And I'm sure we're going to talk about this a little bit more during the question therapy. So the most important point that I would like to mention in my last minute available is that so much in ovarian cancer has changed and is changing, and the future is bright and the present is bright. There's so much more that we now understand. We understand so much more about detection and prevention and who is at risk and how we should look for these women and how it's so important to understand your history, understand where you come from, how it's so important to listen to your bodies. And when you don't feel right, to insist and demand to get the care that you need and you deserve. But also so much has changed in the treatment of ovarian cancer. I began with saying that the treatment nowadays is very different. We don't treat women the same. We truly now study every single cancer. We understand what mutations are driving it. And the care is truly given in a personalized, individualized fashion. And, not only does it increase how well the chemotherapy works, but it also improves the lifestyle and gives the women the quality of life and allows them to return to their lives that are disrupted by this. So thank you so much for this opportunity. It is so wonderful to be with all of you today, and I'm looking forward to the questions.
Dr. Ratner and Dr. Hofstadter, thank you for your time today. And we have a question here from one of the panelists, from one of the participants. Are hormones safe for women who have had a PR positive breast cancer? So I'll ask Dr. Hofstadter maybe to start with that one. I think you're on mute, Dr. Hofstadter.
Find $1 for every time I was told that. I was going to say the answer to that question, and probably every question in this forum, is going to be it depends. The short answer is probably not, but of course it depends on how strongly PR positive that breast cancer was. So, for example, if it was estrogen receptor negative or ER negative, and progesterone receptor like 1% positive, I think that would be it would be considered in that case. If it, for example, was a pre-invasive breast cancer, like a DCIS, and a person had a mastectomy, I would say yes, that's probably safe. So the short answer to that question is it depends. Probably not, but there are certain situations where it might be considered.
Yeah, and I just want to second very much what Dr. Hofstadter is saying, and this is again resonates with what I was saying before, that everything truly is personalized. Again, there's a lot of literature, for example, that vaginal estrogen is very safe even when women have PR positive or ER positive breast cancers. A lot of women live their lives with vaginal dryness and with atrophy and with difficulty with having intercourse. And there's a lot of literature that a very small amount of the vaginal estrogen gets absorbed into the bloodstream. And the great majority of medical oncologists believe that it is safe to use vaginal estrogen in this population. And I also wanted to make a point that estrogens is just one of the modalities that we use to treat these kind of symptoms or hormones. That there's herbal medicines and there's acupuncture and there's a lot of other things that can be done specifically for women with breast cancer for whom, like Dr. Hofstadter mentioned, estrogen should not be the first option.
So we have another question, and ladies, feel free to ask your questions in the chat box. The next question is, are there any new findings correlating the RAD51D gene to breast cancer?
The short answer to that is yes. And again, that's one of the areas where I rely on the NCCN guidelines to stay updated, because if you had asked me that question even as recently as a year ago, I would have said, nope, we don't need to do anything. But on this rendition, there's some evidence that suggests perhaps, notice all the caveats, that RAD51C and D may have increased risks for specifically triple-negative breast cancer. But the data is murky enough at this point that they are not yet recommending enhanced screening like MRI and things like that. That's one of those things where you have to stay tuned. It may very well be in a year that I'm going to be recommending breast MRIs for these folks, but not yet. So possibly, but stay tuned.
Thank you, Dr. Hofstadter. And I just want to take a minute, if there are any other questions, we'll certainly take them as well. We do have 2 more weeks of our webinar series. Next week, we'll be talking about male cancer risks and also the breast reconstruction options with one of our plastic surgeons. We have also our pancreatic cancer discussion. And then the following week, we will have a full session on sexuality and menopause and hormone management. So we'll go into more depth about the different types of hormone replacement therapy that we use. So stay tuned for those on the following Tuesday nights. There's another question about the age of taking birth control pills. Does anybody want to take that one, about how old girls or women should be when they take birth control pills?
Elena, I'd be happy to let you start with that one.
Yeah, I think that question actually, I think that Victoria's question is not the age, because the age is totally fine. You can start birth control pills super young. And,
Maybe family history.
right. And,
Right.
you know, as I have a 16-year-old now, and I don't want to think of my 16-year-old taking birth control pills. It's just the reality. And so, but people take it for different reasons. And yeah, for dysmenorrhea, that periods, it is very, very common and very normal to take it at age 16, even younger. That question was more for family history of breast cancer, whether it's safe.
Yeah, that's what I was thinking. Yeah. I mean, big picture, I mean, the amount of risk that birth control pills theoretically adds to underlying breast cancer risk is exceedingly small. You know, there's a difference between statistical significance and clinical significance. And so even those studies that show a statistically significant increased risk, you have to understand what that translates to is, you know, a point, like, again, I'm just making up these numbers, but the difference is like, even if you double your risk, if your risk is 0.01% and it goes to 0.02%, you've just doubled your risk, and yet the absolute risk remains very small. So without getting too lost in the numbers, big picture is that's where you have to tailor it. If you've got a young woman in her teens, despite a family history of breast cancer, if it is right for whatever reason, control of her periods and symptoms, birth control, whatever, if it's the right thing to do for those reasons, she should do it. The potential additive risk, if it even exists at all, is exceedingly small, even at that age, even with BRCA mutations. So I would do what's right for that particular young woman.
Yeah. And also remember the benefit of reduction in ovarian cancer, you know, so what Dr. Hofstadter talked about, the small risk, but a very, very significant reduction risk in ovarian cancer, you know, 50%, again, like I mentioned, 50% in 5 years, very, very significant, really the only thing that we can really do to reduce our risk.
Yeah, and I saw that chat just pop up. There sounds like the women are ranging in age from 18 to 22. I would say if that's what's right for them, that's fine. That doesn't floor me at all. In fact, we don't even test for BRCA mutations until a woman's 25. So they should do whatever is right for them. You're welcome.
Okay, well,
I love this chat feature. It's so fun.
So we'll try to get all the questions answered before 8:30. So next question is about the BARD1 mutation for breast cancer risk. Dr. Hofstadter, can you talk about that?
Yeah, so that graph that I show in the beginning, I feel like I wish I could edit it because BARD1 is still in the gray zone in terms of, depending on the study you look at, it is associated. It's not associated. It is. It's not. And even less so than RAD51C and D, it's still not clear that it's definitively linked to risk. So I almost wish I could take it off of that graph. And remember, a lot of times people come to genetic counseling with a family history of breast cancer, and then we might randomly find, let's say, a BARD1 mutation. In those situations, I would actually look back to the family history. I mean, the reason they came in the first place is probably because of family history. So you have to take the mutation into context with the family history. So if a person had a BARD1 mutation, but they had like 1 million breast cancers at young ages in their family, I'm going to recommend an MRI based on that family history, not necessarily because of the mutation. So again, this is where everybody comes in with an individual history and an individual family history, and the mutation is just one piece of that.
Yeah. Joanna, I wanted to make sure that we answer Rose's question, because I think Rose's question was a little bit different and we kind of skipped around it. So first of all, Rose, congratulations. That is so amazing to hear. But I think Rose's question is, what is the advice to her kids now that she's BRCA negative? So, you know, Rose, it's a very difficult question, and everything depends on the family history and really on you. So if a patient had a BRCA mutation, and then the children do not, then they have nothing to worry about. So that's, if a woman has a BRCA mutation and she develops ovarian cancer, then that ovarian cancer is explained by the BRCA mutation. And then the children, if they don't have it, just have a population risk. So they live normal lives. If the woman doesn't have a BRCA mutation and the children don't as well, then it's not as helpful because, we don't know why the woman got it in the first place. And we believe that their risk is doubled. But exactly as Dr. Hofstadter said, we won't even test them till they're older anyway. And there's a lot of debate back and forth whether we would screen them and whether we would do ultrasounds to them later in life. Right now, I will tell you that no, we do not. But everything depends on additional family members. Is there really some sort of a risk or some sort of a thought that there's some other genetic mutation that runs through your family? And again, so truly kind of individualized, personalized decisions. Erin, I don't know if you would want to.
You just broke up there a little bit, but I don't have anything to add to the explanation that you just mentioned. I will admit, and Joanna, I'll let you drive the questions here because I'm seeing that there's questions in Q&A and I'm seeing that there's chat. So I'll let you, Joanna, tell me what we're supposed to do next.
So the next question that we'll go to is about melanoma and eye screening. And I think we'll touch a little bit about this next week as well with the other cancer risks. But Ginny's question was, is there anything special to do for prevention of eye melanomas, or do we just do the monitoring with an eye exam once a year?
Yeah, I mean, I think this is where just general, public health, sun protection comes in. So obviously limit your exposure to the sun in between, 10 and 2 o'clock, sunscreen. In terms of special things for the eye, to be honest, I'm not an ophthalmologist, but I think that's where it makes sense to, wear sunglasses and things like that, UV protection. But there isn't any special recommendation beyond, common sense skincare and seeing the eye doctor. Let me emphasize, ocular melanoma is exceedingly, exceedingly rare. It's like a fraction of a % of people per year. So it's very, very rare.
Okay. And next question, this one might be a tough one. There's an article about statins that are inhibiting an enzyme in a pathway involved in tumor growth. Can anybody comment on that?
Elena, do you want to take this one? I have a small amount to say, but not a lot.
Go ahead.
Sure. So yes, the answer is statins, like these are cholesterol medications. And there is some research, at least in the breast cancer literature, that there's something about cholesterol synthesis. And I think it's the HMG-CoA enzyme pathway. Don't quote me on that. But again, this is where my brain is starting to churn. The cholesterol synthesis pathway that does appear to increase risk of breast cancer incidence and may actually, in combination with some chemotherapeutic agents, may actually enhance treatment if you put a cholesterol medication together with certain chemotherapies. It's still very early. There was actually a breast cancer prevention trial that closed early a few years ago trying to look at a particular statin and preventing breast cancer, but it closed early because they had a hard time recruiting because so many people are on statins that they couldn't recruit enough people. But I think that there is some data. There is some data there, and I would, again, stay tuned. I don't think it's at the point where I would tell people to go take a statin if they don't need it, but I'm certainly not going to be sad if you're on it, I'll be honest. So.
Yeah, so I feel very similarly, Erin. I feel like a lot of, because I get asked this question all the time nowadays because of those, of just the news that talks about the statins. But I very much agree with you. I think a lot of women need it, or even if they have a low threshold, I very much like for them to be on it. The literature is very new, and the research is very young, but there's definitely some plausible mechanisms that seem like it would be helpful.
Mm-hmm. And I guess the other plug I will put in for lifestyle is I would much rather somebody like exercise and lose weight and get off of their blood pressure medicines and off of their statin, like eat your Cheerios and exercise, than be on a statin, if that makes sense.
So we'll do a few more in the next 10 to 15 minutes that we have left. The next one is about hormone replacement after a cancer. So we talked a little bit about, being careful with hormone replacement therapy after breast cancers. Dr. Ratner, what about after gynecologic cancers? Is hormone replacement therapy safe?
It depends what kind of cancers. Definitely safe after ovarian cancers. There's just very rare few cancers, something called endometrioid ovarian cancers, that might have high estrogen receptors. That would be the one cancer that we would look and consider other options prior to starting estrogen. But cervical cancer, it is totally fine. Endometrial cancer is the cancer we usually like to wait at least a couple of years for the woman to get away from the diagnosis, because most of these have a very high estrogen receptors. And again, there's many different things that we can do, and the great majority of women get relief with herbal medicine, with acupuncture, with other interventions, with other non-hormonal interventions. Again, everything's very personalized. I have women with very high estrogen receptors, but but there's quality of life by lack of estrogen, that we absolutely do use estrogen in those women. But if women have endometrial cancer or very rare subtype called endometrioid ovarian cancer, we like to check hormone receptors. And if the hormone receptors are high, we like to try other alternative methods prior to starting estrogen to see if relief can be obtained without the hormones.
And I think we'll probably end with this great question. And there's a question about, after somebody has all of the risk-reducing surgeries, if they have a mastectomy and if they have ovaries and tubes removed, what do they need for surveillance for breast or gynecologic cancers?
So it's a great question, and so I'll take the top half, and Elena can take the bottom half. In terms of what you need to do about breast cancer, remember your risk at this point, the remaining lifetime risk is less than 5%. So technically speaking, you could probably disappear from a breast exam forever and probably be fine. But that said, this is where I kind of leave it to the discretion of the patient. It's not unusual for a patient to come in, see us once a year, once every couple years, or get a breast exam from their doctor, looking specifically along the scar lines and to examine the axilla. Is it necessary? Technically, it's not necessary. Their risk at this point is less than mine, quite frankly. Is it nice to touch base and keep up to date and do a breast exam and provide reassurance? Of course it is. So it's never wrong to go back. Of course, if it's a hardship to come in and see your provider, that's one area where you can rest assured that your risk remains quite low.
So from the standpoint of the ovarian cancer prevention screening, women who have had their ovaries and fallopian tubes removed very much should still be seeing a gynecologist. And that is for the sake of physical examinations. If you have your uterus still in place, then certainly you need to get pap smears and exams like that. But there's also a very small chance of something called primary peritoneal cancer, which is a cancer that's like ovarian cancer, but it comes on the lining of the abdomen called peritoneum. The risk is small. The literature I showed you was 1.6%. Anecdotally, I believe that's actually even less nowadays, because we do surgeries in a much more radical way to remove all remnants of fallopian tubes or ovaries. But yes, you should have a physical examination. And there's also a lot of debate whether you should also have a blood test like a CA-125 or OVA1. And that's more debatable. In my practice, yes. In Joanna's, in my practice, yes. We do physical examinations once a year, and we would do a blood test called CA-125 once a year. CA-125 is not a good test. It's a bad test. It has a lot of false positives, a lot of false negatives. I was going to say it's a crappy test, but I saw Joanna previously say that this is all going to be taped somewhere. So now I actually got to watch how I say things. But it's not a good test. There's a lot of false positives, a lot of false negatives. The highest number I've ever seen was somebody who had a cold, whose number was, 1,000, 15, 16,000. And then a few weeks later, it came down to 7. But what matters is that the test, it doesn't matter what the absolute number is, it matters what that number is for you. So it's a trend that's only specific for you. So for you, if we watch CA-125 once every year, then we would know if anything is out of ordinary to what it is usually. So yes, that is what we would recommend, how we would do surveillance.
Okay, well, thank you, Dr. Ratner and Dr. Hofstetter, for a wonderful session. Are there any other final questions? There's anybody else, any other final thoughts from the speakers at all tonight?
Other than thank you, no, this has been really great to be able to touch base with everybody and talk about these issues, and thank you for the invitation. Yeah, I guess that's it. How about you, Elena?
Well, my point, of course, is very similar, but also my last point has to be that of empowerment, that we as our lives, we take care of ourselves. You are your best advocate. The fact that you're here means that you are doing everything you can to protect yourself from whatever can happen, and getting the genes tested, finding out about your family history, understanding your risks, understanding what you can do to risk reduce is what it's all about. This way you make sure that nothing happens to you and that you take care of yourself. And we are here as a family to help you and do whatever we can to decrease your risks.
And I will echo that even though Dr. Hofstetter's group is at the St. Raphael campus and Dr. Ratner's group is at the Smilow campus, we very much work together, and we're here for your whole family. We're here for your, all the women in your family and all the men in your family. Our genetic counselors are close by. We can answer any questions that you have, or if we can't answer them, we can get you to the right person. So thank you to everybody who joined us tonight. And Ruth Ann, thank you for coordinating and organizing. Ruth Ann is our Discovery to Cure program manager, and she does a wonderful job on the fundraising side and patient support. So if you need any extra support from Ruth Ann, she's wonderful as well. And we hope to see you next week for more on Smilow Shares.
Good night.
Thanks, everybody.